Good morning, everybody. Good morning, everybody, and welcome to AIM Impact on Your Health. AIM Impact on Your Health, where every day our goal is to have you learn at least one thing to help you live better and longer. AIM Impact on Your Health is heard each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney, and I'm with you each and every Monday, Wednesday, and Friday from 8 to 9. AIM Impact on Your Health, where each day you'll find current medical news, knowledgeable guests, fascinating health topics, and of course where we do encourage you to call in to join in today. Well, a real special day today, folks. You've been waiting for this for quite some time. It's usually a get 'em up out of town version on Friday. A little different today. We're going to be with our good friend, Dr. Ty Vincent. And we're going to be completing our trilogy, 3 different radio shows. We get the 3rd one today. And he has consented in yeoman fashion to come aboard live with us today. It's a live program with Dr. Ty. And he's coming to us live from the Kona coast of Hawaii. Don't you feel bad for him? But it's 3 o'clock in the morning out there. He was nice enough to interrupt his day for us so that you can have an opportunity to ask him questions live. And you should have been prepared for this. And if not, be prepared right now. You got one crack at this, gentlemen. Take us up on an opportunity today when Dr. Ty Vincent is going to be our guest talking about LDI, low dose immunotherapy. He coined the term. He damn near developed the whole science of this new immunological approach to autoimmune diseases that we're going to be talking about today. So I'll cut to him very early so we have an opportunity to spend a lot of time with him. And right after that first segment, open it up to you. The number to do that, as you should know by now, if you want to talk to Dr. Ty, is to dial us up at 412-825-6262. That's 412-825-6262. Quickly looking at the schedule, you don't want to miss Monday's show. Shannon Gossen's going to be here. We're going to be talking about frequency-specific microcurrent and getting you ready for our conference going to be held in April. Laypersons, their own conference. Practitioners, their own conference. How to use microcurrent in their particular medical situation for their entire family, literally. So more on the issue of microcurrent from Shannon and the conference to be held in April 10, 11, and 12. 10 will be for laypersons, 11 and 12 for practitioners. More on that matter on Monday with Shannon. We're moving rapidly through the month of February. I'll have additional guests that I add to our agenda, and I'll let you know about those on Monday. Don't forget to pick up your copy of the Top 20 Alternative Doctors in America. That thing came together last summer in Phoenix, Arizona. 20 docs picked throughout the country and wrote a chapter in a book. The book is now available in my office. We got a pretty generous supply of them. Stop by and pick one up. Top 20 Alternative Doctors. We can send it out to you too for a slight shipping charge. But this is a one-of-a-kind tome, and I hope you would enjoy having a copy of it. I'm not so sure there'll be a second run for this book, so get an opportunity to get it while you can. Also, the article written by me on frequency-specific microcurrent found in this, not this month, but this quarter, winter of 2015. The Journal of Lifestyle Medicine will help bring you up to speed on what frequency-specific microcurrent, we call it FSM, is all about, and more on that subject as the time marches on. Now look, I want to cut to our guest today. I'm going to take a short break. We're going to open it up after some brief discussion about LDI. This is our 3rd in the series. Other 2 have been in December and January. This is our 3rd installment. The trilogy, as they say in the industry. We'll be right back in a moment with Dr. Ty Vincent. Good morning, ladies and gentlemen. Welcome back once again to AIM Impact on Your Health. Right here in KHB 620 each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney with you on this very special Friday version of the show. We're completing 3 shows on a subject that our guest today literally has reformed, reshaped, and retooled to be known as now LDI. In the past, we called it LDA. This is low-dose antigen therapy, immunotherapy that Dr. Ty Vincent has been able to take to another level, another realm, approaching the ability to correct diseases that you never thought could be corrected before. On our 2 previous shows, we've gone over the classical side as well as the autoimmune side of this equation. Today, he came to us live, folks. He's live from the Kona coast of Hawaii today, and he tells me it's 70 degrees out there in the middle of the night, and it is the middle of the night. It's 3 o'clock in the morning. That just goes to show you what kind of trooper our guest today, who really is quite unique. You'd know that. He's coming to me at 3 a.m. his time, but he's unique in this respect, too. As a clinician, he never really settles for not conquering what he sets out to accomplish. And if it means your diseases, well, he's going to conquer that too. Well, at least that is how I gather our guest today in his quest to correct some pretty serious diseases that he's tipped us up to in the past, and now we bring them to you live. Good morning, Dr. Ty, and thank you, and I mean really thank you for coming aboard today at 3 a.m. What a trooper you are.
Good morning, Dennis. No problem. My wife says I talk in my sleep anyway.
I actually can believe that. And you probably have wise things. I hope she writes down what you say, because I wouldn't want to miss any morsel of what comes out of your mouth. Now, I mentioned we texted each other as I was coming in, and I thought you were in Wasilla, Alaska today, which is your main base of operation. But as I've told our listeners before, you spend 2 weeks in Alaska and 2 weeks in the Kona coast. And my first question I thought was going to be a funny one, which was, hey, what's the temperature in Alaska today? Because we're at 4 degrees here in Pittsburgh. You texted back what, Ty?
It was 19 in Wasilla, Alaska, but I'm in Kona and it's 70.
19 degrees. All right. Well, you're having a heat wave up there in Alaska. We're having a deep freeze here today. It's just a mere price to pay, I guess. We have this occasionally happen to us. But I'm glad to see you're in pleasant surroundings back in your Kona Coast venue. But you've come to us a couple times before. I've known you for a few years, but really took the level of prominence that you so well deserve in October this year when we met at the Albuquerque conference of the American Academy of Environmental Medicine, when you really revealed some amazing work with low-dose antigen therapy that you now coined as low-dose immunotherapy. So for listeners that may not know, and allow them to maybe pick up where we left off, could you literally describe for us what LDA/LDI is all about?
Yeah, briefly, there are a lot of chronic disease problems people have in the modern era that are based on the immune system inappropriately attacking something and then damaging the body in the process. Allergy is one category of this, and that's what happens, but we call it when the body is attacking something that's actually outside of ourselves, like a food that we've eaten or an environmental antigen like mold or dust or pollens or something like that, or even chemicals in the environment. Now, those are things external, and when we react to them, we have illness symptoms that might be from like a headache or diarrhea or eczema on the skin, wheezing, something like that. And we call that allergy because it's coming from outside. If the antigen in question to which the body's reacting adversely is something inside the body, you get what we tend to term an autoimmune disease. And that manifests more like the body's immune system attacking itself directly without an obvious trigger from the environment or from our diet. And really there's very little difference between the two conceptually. It's just a matter of where the target antigen or the target trigger happens to be. And in fact, most autoimmune diseases are set off by either environmental items like gluten, for example, as a food item within the diet is responsible for triggering a lot of autoimmunity, or they're set off by some microorganism within the body, like the bacteria Proteus is the trigger for rheumatoid arthritis, for example. That's been very well worked out. Streptococcus bacteria that causes strep throat can set off several different autoimmune syndromes, like rheumatic fever is the classic one, or gouty psoriasis. So with LDA, it actually stands for low dose allergy therapy. Those are antigen mixtures that are made by a pharmacy in Colorado. And so they have kind of a trademark for that term. When I started creating my own antigen mixtures, either from patients' bodily fluids and tissues themselves, or from different microbiology mixtures to treat specific autoimmune syndromes, I decided I had to call it something different, and I just gave it a more general term, low-dose immune therapy. And the way the general therapy works is to reestablish immune tolerance to whatever it is that the person's reactive against. And that can be done with very complex mixtures of literally hundreds or thousands of different things all put together, because it doesn't harm a person to train tolerance for their immune system to something that it already tolerates. It's a very simple therapy, very elegant, actually, in the way that it works. There's some complex biochemistry there that we've kind of gone over before, and I need to spend time on today. But in general sense, I tell people now, especially the Lyme community, who has a hard time understanding why I'm treating their Lyme disease with a therapy that turns down the immune response, rather than all of the classic methods of trying to kill the bacteria. And I kind of use the analogy now in the Facebook era that we're sending their immune system a friend request to try to reestablish harmony and immunological friendship with this organism, and therefore the patient's symptoms just stop and they become well instead of ill without having to eliminate the organism from the body.
Now you have really put this in such simplistic terms, and listening to you, this seems and should be like no problem, should be able to be correctable, yet there is a long list, a myriad of diseases that plague many of our listeners, plague the entire world for that matter, for which there really, as is found in conventional medicine, no treatment for autoimmune diseases. Could you just briefly, maybe in your own way, describe the myriad of problems that are, if they haven't been called by their doctors as autoimmune, you certainly, and I certainly recognize them as such. And literally, if you're in this category, as I understand it, you got no place to go with respect to conventional therapy to correct the problem. Could you spend a little moment on the wide myriad of diseases, number one, and the fact, why is it that our medicine that we spent so much time to learn about is ineffective and literally will not conquer these diseases if you're going to pursue this in a conventional realm?
Sure. When somebody asks a real broad question like that, I like to think about systems biology, because we all get pummeled with that through medical training. So if you ask me about autoimmune diseases in general, they can affect your body from head to toe, every system. So if you want to start at the head, neurologically, we have autoimmune diseases like multiple sclerosis and Lou Gehrig's disease, or amyotrophic lateral sclerosis. There are other diseases that people wonder if there might be an autoimmune component, maybe even including things like dementia or Parkinson's disease, for example. Those I don't think have a lot of autoimmunity, but they could. Another brain-related disease that definitely has elements of autoimmunity is autism. I'm actually going to be giving a lecture in Orange County next month at the MAPS meeting on the use of my therapy for autism and for pediatric Lyme disease. And I've actually, as an aside on the MS issue, I've been able to demonstrate lately that it looks to me like most cases of MS actually are just a manifestation of Lyme disease for a person with a particular kind of makeup. But eliminate MS symptoms completely by treating them with the Lyme mixture. Moving down, you get skeletal problems. That's really common as a category of autoimmune diseases. Rheumatoid arthritis is the one probably with which most people are familiar. You have a similar condition called ankylosing spondylitis. You've got lupus, mixed connective tissue disease, Sjogren's syndrome. Some of them have names and antibodies associated with them. And if you see a rheumatologist and you have this inflammatory arthritis going on in multiple joints, but you don't have any of the serological or laboratory tests to indicate a particular named diagnosis, you just get labeled as either seronegative arthritis or inflammatory arthritis, not otherwise specified. And so that's a billing code for a diagnosis that they clearly don't know. I've been able to stop almost every case of inflammatory autoimmune arthritis that has come through my door, using either specific antigens or using the stool sample from the patient themselves, because most of these are triggered by an organism living in the gut. There are muscle-associated diseases like myasthenia gravis, which just makes you weak because the immune system is attacking the nicotinic acetylcholine receptor on the muscle. You've got myositis that comes in various forms. I've had 4 patients with myositis that have been able to stop the process by using their own stool, actually. Then you have bowel diseases like Crohn's disease, ulcerative colitis, things like that. We've been able to improve those things using either a mycobacterial mixture for Crohn's or a yeast mixture for UC most of the time, or the stool sample from the person themselves and foods. I use a complex mixture of things in those patients that works generally very well, 80-90% success.
Wow.
So far. And then, there are other things. There are other skin conditions like psoriasis. Psoriasis and I have a real nemesis, villain, good guy sort of relationship. I've been able to eliminate certain cases of psoriasis easily with just a food antigen mixture. And some cases of psoriasis are actually caused by strep, which goes away quite easily with the strep antigen that Dr. Schrader put out. I didn't even have to develop that one. So there are certain cases with good success, and otherwise with autologous sampling, patients themselves I've met with no success using all different manner of bodily things. So I still don't know what causes certain types of psoriasis. Then, the list goes on. There are all kinds of interesting conditions. One of the women I talked to, a patient I talked to yesterday that was new, she's in Vermont. She said that she was diagnosed with Lyme disease, had a lot of complex neurological symptoms, fatigue, pain, and whatnot. She saw a lot of conventional doctors. And they even did a brain biopsy on her. And she's one of the only people I've ever met living that, who's had a brain biopsy.
Oh, yeah.
Sure. So, but what they diagnosed her with was autoimmune demyelinating encephalitis. That they had sort of like a name for this condition based on the tissue. They just said it's an autoimmune condition. And she said, well, I have Lyme disease. Could this be associated? And they said, no, there's no way. And then it's not associated with Lyme disease. And you don't have Lyme disease anyway, because that's not a real thing. And, I was talking to her, yeah, you absolutely have Lyme disease, and Lyme disease absolutely manifests as an autoimmune disease. Because really what's happening is the immune system is trying to attack these bacteria, but the bacteria live inside you. So they're part of you in a very literal sense. They're part of your microbiome, your ecosystem. And so when your immune system is attacking a bacterium that is effectively part of your normal flora, it manifests as an autoimmune syndrome in pretty much every case. And we come up with names for these autoimmune diseases, but in reality, you could debate whether they're truly autoimmune because the body's trying to attack something that's not you, that's not human. It's just such an integral part of you that you're the one suffering. The bacteria, in the case of Lyme disease, isn't going anywhere. It's staying with you forever. So what you have is permanent, chronic, ongoing misery and suffering and inflammation. So we have a way of treating that now without having to try to kill the bacteria.
Now, this thing with Lyme disease, to me, your largest contributions is your ability to have correctly identified an autoimmune component that had been lacking. I mean, we've been looking at Lyme disease for a long time and played it completely as a microbial infection. In fact, you and I both know that if the doctor comes along 5 years after a person develops Lyme disease, they're getting another course of antibiotics. It's just the way it goes. You, however, saw this from a different perspective. The first time anyone really has looked at it from another perspective, once you've shifted and put this into the immunological world, you began to get results that just were never seen before. Could you, for our listeners, and we'll use Lyme disease because, well, first of all, I think you got your personal stamp on that one. Your successes are just unbelievably in the high 90s, if I understood that right in the past. And I would like you, if you could you Lyme's patient, one case maybe that went extremely well and extremely rapid, and then to let patients know that not everything works that smooth. Could you then describe a patient that you felt was Lyme's, and it took a little bit of a battle to get it done, but it was winnable? I think my listeners could really benefit from you in a heart-wrenching way, dealing with a disease you want to conquer, one that you did like a piece of cake, and the other that you had to battle for. Can you do that?
Oh yeah, yeah. And I've treated. I kind of stopped counting after about 80, but I'd say we're up to the 120 or so cases of Lyme patients we've been treating now, and it grows every week. The best success we've had with anyone was a woman I consulted who's from Kentucky, and she had very typical symptoms of Lyme disease. She'd been having symptoms for about 8 years. A lot of neurological problems, headaches, fatigue, brain fog. When people just can't work, they're totally disabled by these symptoms. Joint flares and a lot of pain. We discovered through the course of this last summer we can mail doses of immune therapy to patients. So now that enables me personally to treat people all over the country. I have great colleagues like yourself that we distribute the antigen mixtures to. What I really want long term is to have hundreds of doctors across the country have the antigens to be able to treat everyone, because I certainly can't. But we've been treating people all over the country directly from my own office, and so we mailed this woman a starting dose. And I have to say for a moment that Lyme disease has been so diverse that the correct dosage or correct dilution required for a given individual has an incredibly broad range, and we have to just pick a starting point somewhere, which is based on educated guess and experience and intuition more than anything else. So in this woman's case, the starting dose, the first dose that we sent her, happened to be the correct dose for her, because she had symptom improvement starting the next day. And then what you have to do is we send a small syringe to you through the mail and squirt it under your tongue. She gave it to herself as an injection, intradermal, because she's actually a nurse and knew how to do that, but you don't have to. Everybody else we have just do it sublingually. So she gives herself the dose, and she calls us a week later, which is, we tell everyone to call in about a week so we can assess their response early, because that's what really determines what to do next time. And she says, yeah, all of her symptoms are completely gone. They went away starting in a day or two. Neurological stuff, pain, the sleep. One of the most common symptoms we see in Lyme patients is insomnia, horrible insomnia. They need 2 or 3 drugs to get any sleep. And that symptom just goes away, goes back to normal right away when we get the right dose. It's just an inflammatory problem. So, I mean, she has all of her symptoms, literally every symptom gone completely. Hasn't felt this good in a decade. And her response to the very first dose lasted 5 months.
Wow.
Yeah, exactly.
Wow.
That's not something we tell anyone to expect. Dennis, like if we treat allergies or some other inflammatory thing with LDA or with LDI, it's more typical to have 2 or 3 weeks of a response to the first dose. Maybe 4 or 5 weeks if you get lucky. But yeah, in her case, it's 5 months. And so she just kept on doing great. And when she started to notice symptoms relapsing, we had sent her a second dose to use whenever her symptoms came back. And she gave herself her second dose, I think, in early January or something. The first one was like June or July. So maybe it was December she dosed her second dose, and then got complete relief again, right away. So she's our star pupil. And then I have dozens and dozens of people who just, either with the first dose, if we get lucky, or within 2 or 3 dosing cycles, which have to be 7 or 8 weeks apart, within 2 or 3 dosing cycles, we can usually pin down the right dose for most people. And then they start to see, very quick relief of virtually all their symptoms that are associated with Lyme. But I have had some people who we treat a couple of times and they have flares because we get the dose too high, and then they get scared and they want to stop therapy and try something else. There's so many things out there to do in the Lyme world that are interesting and alternative therapies, and some people, their attention span for something is pretty short if they don't get results right away. And so I've had a number of cases, probably half a dozen or so, who didn't have a positive response right away. And so they decided, okay, well, I'm going to table this item and go do something else for a little while, and hopefully they'll come back. Because what my experience has been with other people is that if you stick with it and you're patient and you communicate really clearly to me about what symptoms are flaring and for how badly and how long, we can, I think, make the therapy work for easily 95%. I would bet more like 99% of people with condition. But for some people, it's really tricky. My toughest case, and I have to pick someone who has been willing to stick with me. He was one of the first guys I started treating, actually, too, back in like May. And he's had Lyme for a number of years. He saw doctors all over the world, and nobody knew what was wrong with him until he finally did enough research to figure it out himself. He saw doctors in Germany and Japan and in all of the U.S., different places. And they all just said, yeah, you just had a lot of injuries. That's why you hurt all over, which is ridiculous. Anyway, when he first came into my office, just the way he got up off the couch and walked down the hall before we got to my exam room, I said, you move like you have Lyme disease. And he just looked at me with this shocked appearance on his face. Like, how did you know that? Because I've seen doctors all over the world and done every test. They didn't know it was wrong with me. I'm like, I just see it every day. So anyway, we treated him, and he's very complicated. I don't want to take too much time on this, but the first mixture I put together to treat Lyme disease was only 16 different bacteria. I had like 7 species of Borrelia, 7 Bartonella, and then Babesia microti, because my understanding of this was much more limited at the time. And so I put that small cocktail together, and the place where I obtained it from left out Bartonella henselae, which is a very key organism in the Bartonella genus. A lot of people are afflicted with that. It causes a lot of neurological symptoms. It's the bacteria that gives you cat scratch disease. And so in this gentleman's case, we started him with this early mixture, and he had mild improvement. Some of his brain fog, some of his pain, some of his fatigue was a little bit better, but still all these neurological symptoms and splitting headaches and electrical shock feelings and stuff. And so I learned a little while later from a colleague who had gotten my mixture that Bartonella henselae wasn't in it. And so I obtained it separately. And in his case, I've been able to, he's the only one I've been able to do this where I've given organisms to separately within the same cocktail. Since then, we just mix them all together. So I gave him the Bartonella henselae alone as its own antigen dilution, and it knocked him flat for a month. I gave him a dose, I think, of 1 part per trillion, which was where I was kind of starting everybody with everything early on because I didn't know what the dose range would be. And his symptoms went through the roof, horrible. We had to put him on prednisone, calm it down, because that is about the only remedy I've seen help combat a flare, and start diluting his dose round after round. And so since we've put everything now back together, it has occurred to me because of his case that in some people's situation who have multiple bacteria causing their syndrome, they might have some Borrelia, Babesia, Bartonella. I've got Ehrlichia and Coxiella, all in this mixture I have now. There's 75 species in the complex mixture I use now. They may very well need different target dilutions for different genus or genera. So if they need like a 6C or 1 part per trillion for Borrelia to get response, but he needs a 9C dilution for Bartonella because he's so much more sensitive to it, what I'm going to have to do for some people like him, and I'm going to start with him this spring if he doesn't start to get better response to the complex mixture, is I'm going to have to fractionate it. And so I spent another $1,200 and I bought antigens separately in different mixtures. Instead of all in one bottle, I have one bottle that's only Borrelia and a bottle that's only Bartonella. And so I've made separate dilutions by genus for this. And so down the road, I think even my really complex cases, I'm going to be able to sort out by fractionating this and titrating them to different target doses by genus, if that makes sense to your listeners. I know it's a little more technical.
Yeah, it's a little technical, but it just points out that, look at that home run you hit with a lady, 1 dose, 5 months, she had no symptoms. And then with another one, you battled and retooled, came back, retooled. I guess the point maybe that the listener needs to appreciate is this response that you're looking for, and I believe is how I walked away from Albuquerque appreciating what you do, is something. Would you take a moment and describe something's got to happen? It can be a good something. It can actually be a bad something. And in both cases, you can celebrate the ultimate ability to conquer this disease, whether it was good or bad. And I believe my listeners could really learn from that little phrase and how it should set the tone. And everybody should feel good about the response. It's the no response that's the problem. Could you please expound on that?
Right. It's back to sort of ancient Greece, Paracelsus, the dose makes the poison, or the basic concept of homeopathy. Whatever's making you sick, we can use to make you well. And so, especially early on in a disease, when I'm treating somebody with Lyme, it was early on. It was a matter of I looked at people who had positive antibody tests and went like, okay, I'm pretty sure you do have Lyme. You have confirmed CDC positive Lyme. We treat them. We expect a response. After a while, it became so effective that I was treating people with negative Lyme disease tests, and that's important to point out to people. Is the tests for Lyme disease are horrible, and I no longer test anyone in any way, shape, or form other than to give them my shot.
Good.
Those with LDI.
Great point to make, by the way. Great point.
Negative tests, and they'll react.
That's such an important point. Don't worry about have a positive test for Lyme's to think that you do or you don't have a disease. That's wonderful.
The testing is so horrible because of the way the disease behaves and the eclectic nature of the different bacteria that might be present in the person. So I would treat someone whose diagnosis was fibromyalgia. It's a really common one. I hurt and I'm tired and I don't know why. And I would say, look, I'm going to give you this mixture at a fairly strong dose because we don't know if this is your diagnosis or not. And so I'm going to give you the stronger end of the spectrum, and there's a good chance that you're going to flare and feel bad. But that's good, okay? That means we now have the diagnosis. We now know what's wrong with you. And these bacteria are what is triggering your autoimmune response, your inflammatory response. It just means that we need to dilute the dose. And so I've tried to always impress upon people, look, if I give you a dose and you have a flare of symptoms, that's only bad for a week or two. That's only temporarily bad. It's really good in the long term because that means that I can guarantee we're going to get improvement of your symptoms by using a weaker dose.
Great point.
The Lyme community is pretty cool with that because they're familiar with the whole Herx reaction. They expect when they get on antibiotics something they're going to feel terrible before they feel better. But I have to explain to those people that with LDI that is not desirable. I mean, it means that yes, we're going to have success down the road, but when we get the dose correct, you will not flare first. You should not. You should not feel bad even for a day. You should only see improvement in the symptoms. There's no die-off expectation.
Wonderful. Now, you expounded on Lyme's. I'm fascinated when you speak about it. For my listeners, I guess the point I would like to make is you've discussed Lyme's. The list is as long as your arm in autoimmune diseases, and the fact that the response can be good or bad, that you just have to work with it, means that you could have inserted IBS or Crohn's or MS as a disease, and it can go just the same way as it went for the Lyme's, that the sky's the limit when it comes to the ability to actually correct autoimmune diseases literally for the first time I know of. And it's all due to that stick-to-itiveness of yours. And I'm glad to hear that you're well up over 100 cases of Lyme's alone, and you're batting somewhere above 95%, and that is the message of hope for people who have Lyme's or any other autoimmune disease by just finding that antigen. Get the antigen, and you will fix the problem. What I'd like to do, Ty, is take a short break and sort of switch gears, allowing people who are listening to us right now who may be afflicted with who knows what, that might have really like the opportunity to ask you questions. So we're going to take a short break. The number to call up and talk to Dr. Ty, he is live today from the Kona coast of Hawaii, is 412-825-6262. That's 412-825-6262. We'll come back. I'm going to ask you about a rather unique set of disorders you referred to as yeast-related, because I think that's a new thing that you're introducing that I haven't never heard before, and then allow for a knock on the door for someone to ask you a specific question. Okay, Dr. Ty?
I'm good.
All right. You're with Dr. Ty Vincent today, live from the Kona coast. We'll be right back in a moment with Dr. Ty. Good morning, ladies and gentlemen. Welcome back once again to Impact on Your Health. Here in a special Friday morning version of the show, we have with us Dr. Ty Vincent. He's live from the Kona coast of Hawaii, spending his morning at 3 a.m., folks, with us to give you the opportunity. If you'd like to ask questions of him, that's why he's aboard today. Give us a call at 412-825-6262. If you have a question for Dr. Ty, we'll try to get to as many as we can before our hours expired. And while we're waiting for you to decide to come on in here, I've been talking to Dr. Ty off air because I felt that to mention a couple other points would be helpful to you, especially this group of disorders that you've identified to be the cause and associated with a whole host of problems you've never recognized as yeast infection related. Could you take a moment to take this new category of disorders? You literally came up with this on your own, and expound and clarify this for my listener to help them out.
Yeah, certain things have had pretty obvious association with yeast over time, like women who have recurring vaginitis problems, certain digestive system things. People become aware that yeast sets off a lot of inflammation when it overgrows in certain body compartments. What I've found through the years is that some people who they may start out with a yeast infection, you use the word infection, it usually starts with that. They've had antibiotics for things various times or whatnot, and they get yeast overgrowth and they have a yeast infection. If that isn't handled quickly and successfully, it evolves into an autoimmune process quite quickly in a lot of people. And so at my office, anytime we give anyone an antibiotic, we immediately give them an antifungal drug with it just to prevent the recurrence, because I've seen it hundreds of times now. And the hypersensitivity reaction that builds against the yeast organism can manifest autoimmune type symptoms or inflammatory symptoms in pretty much any tissue in the body. One of the most common just systemically is people, the fibromyalgia diagnosis, which is full of nonsense and made up, but a lot of the people I've seen over the years who were labeled as fibromyalgia because nothing made sense, I would give them fluconazole. So this is my challenge to see if someone has an autoimmune or an immune issue caused by yeast. I can give them something that kills yeast and see if their symptoms respond. So, on an antifungal, like fluconazole at high dose for a couple of weeks, the fibromyalgia patient, their fatigue gets better, the brain fog goes away, their muscle pain stops. You go, oh my gosh, that was the answer. And then if they have a hypersensitivity, which most of these people do, when they stop the antifungal drug, their symptoms all relapse within about 2 days. And if anyone out there is listening and has experienced this, then that means you have fungal hypersensitivity. So a lot of the alternative medicine community that's all about the candida craze will say, well, that's because fluconazole doesn't really kill it. It just hides it your cells. It's waiting to reemerge. That's not true. That's nonsense. It does kill it. It makes it go away. The problem is you can't sterilize people from yeast. And this is why it becomes a chronic autoimmune type of situation. When you can take fluconazole at 1 million milligrams a day if it didn't kill you for a month and be completely free of yeast. And then when you stop it, within 48 hours, you become recolonized because the stuff is in the air. It's on the surfaces. It's in your food. It's everywhere. So you can't permanently decontaminate people with yeast. You're going to get it back. And if you have a hypersensitivity response to it now based on your immune pattern, you will be sick again in just a couple of days. It's not because you have a lot of candida. It's because you have a little tiny bit of candida. We've shown that some of our sickest patients with fungal hypersensitivity, you do a stool test and they have no candida in their stool, no yeast at all. And that's because their immune system is killing it as aggressively as it possibly can. Point. So the absence of yeast in your stool is more likely to indicate a yeast problem than having some yeast in your stool. And you just have to think about that. It makes sense. Anyway, the diseases we've seen triggered by yeast sensitivity, again, go from head to toe. You have this brain fog and whatnot you can get with fibromyalgia. You have joint muscle pain issues. You have rosacea on the skin. We have irritable bowel syndrome or ulcerative colitis in the bowels. We got just weird arthritis conditions that don't fit another pattern. We got autism. Autism is commonly associated. And in women, endometriosis is almost always a yeast-associated inflammatory condition. And so is interstitial cystitis, very commonly associated with yeast. But that one's complex. It'll have food antigens associated and yeast, and then some other urinary things that we use autologous sampling for.
All right. Tell you what, Dr. Tech, we're getting people who want to come in here and ask you a question. I know that's why you came live with us today. So why don't we invite in our first caller today? Come on aboard. You're with Dr. Ty Vincent. Go right ahead. What's on your mind? Hello.
Hello.
Hello. Go right ahead.
This is Dr. Roy Carey, by the way.
Hello, Dr. Roy Carey. Oh, my goodness. One of the fold. You know, Dr. Carey, I'm sure, Ty, he's at AAEM each and every time you present.
Oh, thank you, Ty, for your contribution to medicine. A couple of specific questions. Yeah. Do you add anything more to multiple sclerosis, myelin-basic protein, anything like that? I'm just going to rattle my questions off.
Oh, good.
Where do you get hyaluronic acid for skin lesions? You dissolve things like that. And if you thought about cancer, I shouldn't mention that word on the air, but is there any autoimmunity involved with cancer?
Well, with the MS question, yeah, I've been experimenting with a sample of myelin-basic protein because if people don't know, that's the specific protein target in the brain tissue that the immune system's attacking. So I thought, well, if I can get the isolated protein, maybe we can symptomatically control this condition without even worrying about what the trigger was. And I've had, I think, opportunity to treat about 5 people with MS now using the myelin-based protein, and I've had positive response in 2 of them so far at the starting dosage that I picked. So the others, I'm moving to stronger doses to try to pin down what the range of effective dilutions is for the MVP before I send it out to the practitioners like yourself and Dr. Courtney, because I need to know what dose to give people and where to make dilutions from. But what I can tell you about MS is that now my feeling on the matter is the vast majority of people who have what we call MS actually just have a manifestation of Lyme disease. So once I'm getting a response to the myelin-based protein from my test group, I'm starting to incorporate the Lyme antigen too, just to try to make them better. I know what their dose is for MVP, and I'll just use a combination. So my expectation down the road is for MS to probably use a combination of myelin-based protein and the Lyme mixture, and I expect to get an extremely high rate of success with that, but it's early. Hyaluronidase, so your question points to the fact that I use tissue samples to make autologous or self-derived antigens for certain kinds of autoimmune disease. And I'll take a skin biopsy from a person and then dissolve it with an enzyme called hyaluronidase, which breaks down the ground matrix of the skin. I got it from Henry Schein. They sell little boxes with 3 or 4, vials in it. And I think from a certain other just general conventional biomedical offices sell it. It used to be used to inject nasal polyps and things like that. So it's not an uncommon thing. In fact, that's how LDA was discovered back in the 60s, was with Dr. McKeown injected nasal polyps with hyaluronidase, and it had a trace of beta-glucuronidase in it, and the guy's allergies went away. I mean, this has been used for a long time. The last question, I've forgotten. What was the last question?
Is cancer involved with autoimmunity?
Oh, right. Yeah, I've had at least 20 people ask me about that. I am not aware of an autoimmune mechanism in cancer. People can use this for cancer. And my original response is no, I don't think so, because in cancer, what you really want is you want a more aggressive, effective immune response against the cancer cells, so your immune system will kill it. What LDI does is turns off a specific immune response against something, and you wouldn't think you'd want that in the context of cancer. But a lot of people with cancer have other autoimmune diseases, and those ongoing inflammatory processes are potentially part of why they got the cancer, because the immune system is distracted with this chronic inflammatory problem and doesn't have the resources to devote to their cancer. Same reason why a lot of people with autoimmune or allergic disease have toenail fungus and wart and herpes virus flares and shingles flares, because these are opportunistic infections that their immune system just doesn't have the resources for in this context. So I would say that anyone with cancer, if you could treat any allergies they had, autoimmune processes that they had, they would benefit them in the big picture. And I mentioned this, my wife is one of the people who asked me about the cancer question recently. And she's honestly the most important person in the world to me, and she helps balance out my thinking, because we think so differently, which makes a good couple most of the time. She says, asked me about cancer, and I explained to her why I don't think it'll work, and she says, I'm sure you can figure out a way.
Oh, I love her. I love her.
There's a way to make it work. You just stop thinking about it not working and figure out how it can. So I promised her I would devote some meditative time at some point to how to use an immune technique like this, maybe not exactly against cancer. And what I came up with so far, I'll let you know, the first people to know, just like we've noticed, if we give somebody too strong a dose of the right antigen, they have a flare. Their immune response against it gets worse. Maybe we can take advantage of that with cancer. So if we can get a sample of the cancer cells themselves and give the person a strong dose, which is basically a cancer vaccine. I mean, the difference between a vaccine and desensitization is dose, and the eventual goal would be immune response. So, beta-glucuronidase is a very strong immune stimulant for a reaction. And I've proven it doesn't have to be a good one. It can be a bad one. So perhaps what we'll do is get cancer tissue samples, make a dilution, and give them like a 1 to 100 dose or some very strong dose and see what happens.
There you go. I just love your wife for encouraging you and instigating that mind of yours to work in the right direction. I think a lot of you, but she who lives with you knows you best. She's wise counsel, very wise counsel, and I'm glad that she continues to stimulate you to move into other realms. Not get too comfortable with your successes and move into the problem areas that can really benefit from your thinking. Roy, any additional questions? It's so nice for you to call in today, Roy. Dr. Roy Carey, sort of the godfather of alternative medicine here in Western Pennsylvania. Great mentor to me, and so helpful in helping me develop much of what I do here in my practice. Any other questions now that you have them?
If we get a failure on the 55 mixture, which we have now, so we look for the next mixture you have putting together?
Talking about Lyme disease now, Roy, aren't you?
Lyme disease. We have the 55 mixture.
We got the 55 in, and are we going to stay with the 55 antigens, the species, or is there going to be part 3?
Well, the one I have now is actually 75. That's probably what you have.
Okay.
But you should email me the details of the case. There are a couple of possibilities. One, they may have an organism that gives you the same syndrome that isn't in the mixture. Some other things to consider are the rickettsia, chlamydia, mycoplasma, and so I have a mycoplasma chlamydia mixture. Anything that becomes an intracellular bacterium that's saving you could trigger this type of syndrome. So there might be a different organism entirely to you, but it hasn't been classically associated with, quote unquote, Lyme disease. The other issue is maybe this person is the first one that needs a stronger dose. I don't know what dilution you've worked your way down to in terms of strength. The strongest dilution I've had to use on anyone so far myself is 5C, but that, there could be someone out there who needs a 4C. So if you email me the details of the case, maybe I'll send you something new to try, or have some other, quasi-brilliant idea for you to try. So that's such a specific case. Email me the details, and people do this every day. I have clinicians and patients contact me every day with specific cases, and that helps all of us learn so much faster. As far as my philosophy goes, one thing I've taken to saying a lot of is a prerequisite to learning is ignorance. Because you can't learn anything if you already think you know the answers. And so that's where my wife came in to point out to me that I was so ignorant about my thinking in the cancer realm. And I told her that statement I like to say, and she added, and humility. So now I say the prerequisites to learning are ignorance and humility. You have to realize you don't know something.
Wonderful.
In order to learn something.
Well, the listeners' take-home message from our little dialogue between the three of us, and I'm glad this turned into a three-way, is that you keep on moving from one antigen. You look for that response, whether that's a good one or a bad one, positive or negative. It's the response that counts. If you get no response, you start moving through the mixtures until you do. I believe that's the take-home message. Any need to expound upon that core principle, Ty, that you got across to us in Albuquerque and that I follow continually today?
No, I mean, that's key. Keep on trying to, basically you cling to the belief that there has to be an answer. There has to. Your patients come in and they're sick and they're miserable, and the conventional medical approach is to run a few tests and tell them there's nothing wrong with them. Go see a psychiatrist. It's all in your head. And I absolutely hate that. And so to me, I take it personally. Like, no, there's something I haven't figured out yet. There has to be. Or this person wouldn't be suffering. This person wouldn't be sitting here in front of me. And for some of my patients, it has taken me 7 or 8 years to figure out what to do for them. And those have all been Lyme patients now that I know. You know, but I've had some people just horribly ill for years and years, and nothing I ever tested or looked at or tried made a darn bit of difference for them. And then I came up with this treatment for Lyme this year, and I tried it on them, and they responded. I have 3 or 4 of these people, and I'm like, yes, I can cross them off my list of perpetual failures. So you just have to keep sticking with them, trying something new. Don't keep trying the same thing over and over again. And that's where I get frustrated with, you know, the way we've treated Lyme disease for so long. Is it has really been fairly ineffectual for the large percentage of people, but it's like, this is what we got. Well, you got to stop thinking that way. You got to start thinking about what else can we do.
Great point. Roy, any final questions for Dr. Ty? Those are great questions. Anything else now that you got his ear?
I've been using my kinesiology to get an approximate dose, but maybe I'm going to stay in 2 weeks. I haven't had any terrible responses by being 2 weeks. So I'm going to go get more gutsy and start with
Definitely
6 even.
Yeah, I'm glad.
Thank you very much. I'm going to get out of the way and let somebody else on here. Thank you very much.
Okay. But I'm glad you mentioned the starting dose. I tried that too. I'm not a very experienced kinesiologist by any means, but I tried doing self-patient testing with the vials to see what the right starting dose would be. I blinded them and myself and handed them vials at random and had them kind of self-test to pick a starting dose. And I didn't get any better success with that than I did by guessing. So I went back to guessing because it's quicker. But a more experienced kinesiologist, muscle tester, might be able to nail down a better starting dose. But however you choose to pick your starting dose, you have to move along based on clinical response. So if nothing happens, you go stronger. And the strongest, like I said, I've had to use is 5C. So I'll max out to 5C before I think about trying a new antigen if I'm pretty sure about what I'm using is Lyme. And then, you know, if they get a flare, you've got to go weaker. So the clinical response is the gold standard in this. It has to be. And that requires communication from the patient. And we really try to impress that upon them. The only way to figure out how to treat them is for them to communicate with us every little detail about what happened.
And I think another take-home golden rule that I've learned from you, you know, if we get that response, that whether it's positive or negative, we go, aha, we found the antigen. Now we just got to work on dose. And you don't get the next injection until at least 7 weeks. The point I'd like you to elaborate upon is if you got no response, the wait of 7 weeks is completely unnecessary. How quickly you can go back with the next one so that we can accelerate this process. If you waited in groups of 8 weeks, it could take a decade to get through all these mixtures.
It takes a long time. And, you know, it's funny that you asked me that now, because just this week, I mean, there are 2 answers to your question. One is if you have a new antigen to try, like we were talking about Roy's case, if you tried the Lyme mixture and now you think, well, maybe that's not it, you can use the mycoplasma chlamydia mixture. I usually separate them by a week or so, just to make sure that you have enough time to see any response to the previous antigen occur. But you can give a new antigen anytime because it doesn't have to wait 7 weeks. So if you're trying different antigen mixtures that are mutually exclusive, you can give the person a new one every 7 to 10 days in your search for the triggering, antigen. What we just decided this week, is I was talking to a couple of new Lyme patients around the country, it dawned on me that if I send them a dose, because this does take so long, this is the most frustrating part of it, trying to find the dose, it takes several cycles. If I send you a dose and it has no response at all, then what we're going to try doing is send the next stronger dose along, and you can use it just in 2 weeks. And I think what we're going to do with that is identify whether this is really the right mixture very quickly. What I don't know yet is when they do get a response in that pattern, like, okay, you take the 8C dose today, and in 2 weeks, if there's no response, they give you the 7C dose. And then if you react to that negatively, what dose do I give you next time? I don't know yet what the right answer will be, so I will figure that out, and then I will pass that experience on to everybody else so everyone else can start using this concept. So we're going to try that in a couple of people, in everybody actually now. I'm just going to say, okay, look, this is what we're going to try for a while. You have no response. Just in 2 weeks, I'm going to give you the next dose, this next stronger dose, and we're going to do that every 2 weeks until we see a response. And then at least we're going to be able to determine very quickly whether this is the right cocktail for you.
Perfect. Well, Ty, we got 3 blasts from our good friend Bill in our control room signaling our time out of here. This was just a precious opportunity that you gave us today. coming aboard live from the kind of coast of Hawaii, and my gratitude to you once again for doing such a yeoman's job and with such mental clarity at this time in the morning, that you function very well at this time in the morning. I want to thank you, by the way, listeners. We'll put all three of these together. There's going to be a disc coming. All three of Dr. Ty's shows will be on. I'll get him a copy of it and let him give the final word on if it's okay. But I want to thank you for coming aboard today, and look forward to sometime in the near future bringing you back. We can record it sometime other than the day and not make you go through such a pace. But thank you, my friend, for your participation today.
Oh, you're welcome. It's been my pleasure.
All right, there you have it, folks. Dr. Ty Vincent, the extraordinary physician who's helped literally develop autoimmune treatments that you just got to try. I want to thank you for coming aboard today. I look forward to being with you on Monday with Shannon. So until then, this is Dr. Dennis Courtney with Dr. Ty Vincent and Dr. Roy Carey saying so long for AIM Impact on Your Health.